Hi, I'm Cindy Brock from the Agency for Healthcare Research and Quality, and I wanted to ask you about training the navigators. These people are on the front lines, and you're basically asking them to improve the health literacy, health insurance literacy of the population. And it's an area which I believe it was not prescriptive in terms of the federal government. So tell me, how did you go about training them? What resources would have been helpful or could still be helpful for you in doing that? And maybe reflect a little bit about, if we do this well, how that affects some of the problems that you guys have identified in terms of high deductible plans, that if people really understood at the point of enrollment what that meant, that we wouldn't see some of the data that Karen reported on, and they would make informed choices that suited them.
Should I take that? Well, can I mention something first? Sure. In Louisiana, all I can speak to is what I saw in Louisiana. I think that there was a missed opportunity of not involving the insurance industry. I mentioned that before in this whole process, and because they're the experts on insurance. I think that the navigator training was minimal. I mean, everybody had to go through a certain amount of training, but there were some navigators that never had insurance themselves.
I guess if I could just try and redirect a little bit, because it's not about the substantive knowledge about the insurance plans that I'm trying to get at, but the skills of how do you make sure that you're confirming understanding, that people know what they are enrolling in, and explain these terms in language that they could understand?
Right. Well, I think that one of the issues was that there was such a variety of navigators, some who were very versed on insurance and deductibles and copays and how to explain that, and there was others who had other people who were hired as a navigator who had never had insurance themselves. So they were trying to learn themselves. So it was just a kind of across the board, and so it was very difficult.
So I think we sort of had I'd like to think my network has a pretty good best practice. We had in New York State, you had a 2-day sort of static training from the Department of Health, which is in classroom-like training, not a lot of role play, a little bit, but that was the first basic training. And then they had they have like a refresher to maintain your certification in, sort of static webinar trainings with some interaction questions, which were great. And we do about 8 or 10 of those every year. But my network, what we do is we establish a learning community. And we have monthly meetings. And we try to have people do role plays. And we have a learning community where people can share, okay, what do you do with this kind of problem? What do you do with that kind of problem? I have a contract manager who's like an on-tap technical assistant if there's a problem, and to sort of troubleshoot and walk people through if they forgot something, or if there's some kind of thing. And I think that you really need to develop learning communities for the navigators so that they have like trusted people where it's safe to be wrong or to make a mistake or to practice a way to get a concept across with a patient. And then we can also provide patient-facing materials out to that learning community that I think are really helpful too. So I think that's the way we've approached it in New York.
In California,
no, I'm sorry, go ahead.
Okay. In California, we had a health insurance exchange. And with that health insurance exchange, they set up a community advisory board, and they also set up a board and had 9 health insurance companies that were able to be part of the exchange. So no matter where you were in California, your choice of health insurance came from those health insurance companies that were part of the exchange. So they initially started the enrollers with a 5-day training, which we all thought was a little time intensive and should have been out a little bit more because it overloaded folks with knowledge. And then after that, they had quarterly meetings, and the quarterly meetings were quite robust in terms of when people talked about all the challenges and issues and then tried to problem solve and take that back to the board as well as the community advisory board of the exchange to say, these are some of the challenges that people were having. The navigators were from the communities that they served. So they were people who spoke the language, who were part of the culture and who were able to negotiate this new culture that was coming along called health insurance, as well as the culture of people who were trying to use it, and had an opportunity to speak with people from other cultures and ethnicities about what were some of the common challenges that they were having, and do some common problem solving or joint problem solving also. But it does take time, and it takes resources to keep that training current and going on, because this was a moving target also. I mean, every quarter something was different in terms of the regulations or what they were learning, those type of things. So it's an ongoing process.
In Louisiana, there was no support like that. I mean, it was strictly an online course. You did it on your own, and then you were a navigator.
Are you talking about, was there any mechanism to confirm understanding?
Right. We're teaching health literacy skills so that the navigators would know how to confirm understanding, how to explain things.
So let me
Like
translate.
teach-backs and that type of thing.
Teach-back, yes, yeah.
Well,
So there was some confirming understanding with teach-back.
well, we do that at the clinic for health brief. So we were used to doing that. But as far as formal training, no. It was an online course. Get your navigators in place, have them finish this online course. They get, we had to send a certificate down to the Louisiana Board of Insurance so that they knew who was out there as, quote, a navigator, and that was it. You're on your own.
And just to jump in, in the federal training, the online course, the little module that is to teach about health insurance is it's too basic. And I know they're working on revising that. I think maybe not for this fall, but for the next year. But, feedback into that process, I'm sure, would be welcome.
I'm glad Karen jumped in. We can ask questions, by the way, not only for the panel, but for Karen, who was our first presenter.
Didn't mean it.
Ruth?
Karen, I have a couple questions I think you can speak to. One is, I think everyone has spoken to the complexity of health insurance. It's the law, it's complex, and the big challenge is how to get to something that's understandable, something that's simple enough to understand. And so I'm thinking, and the trust issues that are on the ground for people trying to get people to enroll and use correctly, which is, our national goal with this. So I'm wondering about the role of transparency in getting to clarity and eventually to something that is understandable. And so it seems to me that the transparency provisions, which were a part of the law, are actually a critical ingredient that's still lacking. And you mentioned it, but I wondered if you could sort of explain to us what that means so that we all understand what those transparency provisions might mean to the process overall, and whether or not sort of pushing towards that transparency as a part of what's needed in order to have health literate processes might be an avenue for action.
Sure. So there's two basic parts of the transparency. One is the SBC, which is supposed to make more transparent what the plan rules are. What benefits are covered, when does the deductible apply, when is it passed for the first 3 visits, and so forth. That's supposed to be a simple, easy to read document. It's actually not that simple, but it is there. That has been implemented back since 2012, and everybody has it. So if you're willing to take the time and go get the SBC for all the plans you're thinking about and analyze them and see what they're different and see how would I explain these differences to people, I think it is still a very important tool that can be used. And to the extent that it's improved, I think it will help make clearer sort of what are the meaningful plan differences, and it will help the intermediaries draw out from people what are the meaningful differences for them. The other yet to be implemented are the transparency data that plans have to report about how well they're actually doing what they said they were going to do. So how well are they enrolling people? How much are they keeping people enrolled? Are they actually paying the claims for the covered services? If there's a network, how many times do people have to go out of network? And that transparency is important for multiple reasons. One is if you could develop, kind of performance measures, kind of like little consumer reports, dots, right? People would look for the plan that pays their claims reliably on time and almost never denies them. And they would maybe shy away or be willing to pay a little more to shy away from the plan that doesn't get any good circles on that one because they don't pay their claims. So that, I think, would help people recognize important differences in plans that nobody can see today without a whole lot of digging and expensive market conduct exams. Secondly, I think it promotes, right, there's a sentinel effect. Once you measure things, right, we learned this in graduate school, then that creates bias. And so the plans they will want to have better ratings, and so they'll pay a little better, they'll try to make their networks a little stronger and so forth. So it does that. And third, I think it really helps with oversight. So insurance regulators, it's very hard for them to see these problems now in plans, so people keep having them. They keep boomeranging back with the same problems. It's like, wow, I just fixed that last week for somebody else in a different plan, and what's going on with the way, whatever is going on here. So I think it can, and it's impossible. You think about the billions of insurance transactions that take place every year. Regulators can't possibly keep track of that, but they could if they got this spreadsheet of data every month, and they could just start, very simply kind of identifying outliers. So I do think that is a critical component. It is very slow off the blocks. It was supposed to be one of the first things. The Senate wrote this in as, one of the early investments. They wanted the non-marketplace plans to start doing this in the first year in 2010, and so we're a little behind schedule.
Is anyone reporting it?
No.
Okay. I think that's important to know.
No, and the early implementation that has just been announced by the federal government is going to collect very little data. It's going to be a long ways down the road, I think.
I think on transparency, one of the issues that's been problematic from the patient perspective is the not a lot of disclosure on what the networks look like. You can, find out provider by provider. It's very laborious, but you always have to confirm by calling the provider's office. You can't just rely on the plan, and sometimes the plan's right and the provider's wrong, and sometimes the provider's wrong and the plan's wrong. So that's like a very time-intensive thing from the navigator perspective and from the consumer perspective. And I think there's been a real push from the consumer kind of good government type groups to have the government rate the networks, commercial, non-commercial, the size, the t-shirt size for a network. Is it extra large? Is it large? Is it small? And, I think with varying effects, some states have adopted that, some federal, some places have not. And I think that's a big desire from the consumer side. They really care about networks after cost. Cost is first.
Once again, if you identify yourself when you come to the microphone.
Hi, my name is Virginia Brown. I'm from the University of Maryland Extension. I work on the Smart Choice program, and then my other hat is I'm the action team leader for the entire system nationwide to become leader in health insurance literacy. So my question really has to do with consumer education. Twofold. First, we're looking for alternative methods to go ahead and reach and educate consumers around health insurance literacy. And what methods have you seen to be successful to kind of augment the face-to-face communication? And then second, if you had to choose two things to focus in on around use with health insurance, what would they be?
I can think of nothing besides face-to-face that works. I'm sorry. I mean, I think a lot of our government folks say, oh, we'll set up a website for that. And it's like, okay, who's going to use that? I mean, but we're, again, I'm dealing with the last mile people, this is like our network is dealing with those hard to reach people that aren't, the people who are going to use the web are going to use the web. So it depends who you're talking about. If you're talking about middle income, predominantly, white populations who are English speaking, I think there are non-one-on-one resources that probably work. But I don't think it will work for, people from other cultures or, I think it's going to be much harder to use anything but one-on-one. And I'm sorry, I know that's not the answer you wanted to hear.
I think there's a variety of things or a variety of answers to your question, and it really is dependent upon the audience that you're trying to reach. We have a group of young people, one of them just turned 25 in our office, right? And it is easier for me to communicate with her by sending her a text than having a conversation.
Teach your health insurance through text?
Who knows? Right? I'm just talking how I communicate. You know, when I want her attention, I send her a text, right? And so if you're talking about that generation, right, and how they communicate, I have seen them all sitting in the same room on their smartphones, and just and that's how they communicate. I'm from a generation, you need to talk to me. I need a face-to-face type of thing. But we're raising a generation who gets their information in different ways. So depending on who we are targeting in terms of the communication, it would depend on the strategy that I would use in terms of how I want to best communicate with them. When Beyonce dropped her video Lemonade, our Facebook blew up, right? So maybe we give Beyonce to communicate with people. I don't know, in terms of the video, because she, you know, there were discussion groups about, you know, the issues that she brought up in this video that she dropped on a Saturday night, okay? So who do we want to talk to? What language and what means are they communicating with, right? And that's what I would say, just in terms of, you know, look at who do you want to speak to and how are they communicating. For me, face-to-face, there's never a replacement for that. I think that what type of media that we use is crucial also if we're using newspapers in ethnic communities, because they're very reliant upon their local newspapers, which means that you're going to need translators, right? So that's what I would say, you know.
But you know, whatever the means, the health literacy principles are don't overwhelm people, use plain language. The video, the illustration, the animation, whatever, but they help ground people and teach it to them. But you also have to do a teach back, or you don't know if they got it or not. If they understand it well enough, not just to recite it to you, but can they act on it? Can they use it? And can they retain it?
They might be able to teach it back to you right then, but
then can they retain it? Yes.
A week later, will they have
That's important, and I think that if you that the navigators need to be skilled in that, and how to facilitate a conversation where they're going to know that the client or patient understands all of the aspects of enrollment. Instead of just saying, "Do you know what to do? Do you?" You might have a bob, head, but really, do they understand it?
I think the chart that I put up about how often people use their insurance also maybe cues the content of the lesson and sort of how you convey it. But recognizing also that somebody will begin the year in the I never use my health insurance chart and then fall off their skateboard and break their wrist the way my son did, and then all of a sudden they're going to the doctor all the time and they're using their insurance a lot. So I think it's not enough to just sort of teach people the basics. You need to, and I think you can't teach them everything. I'm still getting stumped by stuff. I'm almost 60 years old and I keep finding new things that I can't figure out about my health insurance. So, but I think, helping them to connect to the experts, please God, let there be more of them, so that they know who to call, so that they can begin again or pick up where they left off, I think is got to be a big part of the important lesson too.
Thank you.
Lindsay?
Yes, hi there. Great panel, really very interesting. My name is Lindsay Robinson. I'm a pediatric dentist from a rural community in Northern California, very different than where Janet lives. I also represent the American Dental Association. My question is related to the pediatric oral health dental benefit. As in covered California, our exchange, we have, it's offered as a standalone plan. There is a family plan that includes adults as a standalone plan. And now our exchange has decided that all health plans sold in the exchange have to include a pediatric dental benefit embedded in the plan. So I know how California does it. I'm really curious to understand how New York has structured benefit. And by the way, I think it's a glaring omission that adults were left out of that dental equation, just glaring omission. So I'm really curious to know how New York does it.
Sure. In New York, if you're going on the exchange and you're going to be eligible for a subsidy, you really don't want to be have the pediatric. You don't want your kid in the commercial coverage. You want them to be in the Child Health Plus coverage because there's no co-payments and there's no deductible, and it has dental. So that's why. So most people are driven for the pediatric part. We tend to, you know, I mean, there are some people, because of network concerns, they will have their kid be in a family plan, but they are also willing to pay a lot more for that privilege of being in that network. So that's, and then they'll have a pediatric dental package. I think the bigger problem actually is what you ended with, which is for adult dental. It's, you know, we have 11 plan offerings. It's extremely difficult to understand dental coverage. It appears that in many cases it would not be worth it, and because it's not clear what the dental carriers are really paying for or not.
And dental insurance is not actual insurance.
Exactly.
It's a prepayment plan.
So I think that is, I mean, I don't know if I'm allowed to admit this, but I think that's an area where, and I'm a pretty good, like I've been doing health law for, 25 years, like a lot longer than I'd like to really announce. And I am concerned that I don't understand all the dental offerings and the ramifications. And we print them out every single year. We go the extra mile and go to each carrier's website, print out all any kind of summary and benefit coverage like document they have and more, their brochures, and really try to study and self-educate ourselves on it. But I think that level of deep dive would be an incredible improvement to navigator trainings everywhere if we really understand dental offerings better so that we can help guide people through those choices. Because it's not clear that they're great choices, or they may be, but we just can't tell.
Thank you.
Michael?
Michael Pasha, Boston Medical Center, Boston University School of Medicine. I'm going to bring up a slightly different perspective than has come out in the room. Maybe people share it, maybe people don't. But, and this is going to lead to a question, but first a comment. I'm offended by the discussion of how little training people got, and ostensibly at a certain level, usually in healthcare, we aspire to have training. This program, as successful as it's been, is basically an assault on the whole concept of social work and the role of having an empowered, trained, educated health practitioner in various levels, right? So at some level, the idea of sending people out and saying, well, they're from the community, they'll understand how to communicate with people is just not enough. It's just not enough. People need to be trained. Now, so my question is relating to scope. I've had the opportunity to listen to some of the phone calls of some of the interactions and then also to observe some in-person interactions. And people will talk about whatever they talk about. I mean, you have an agenda for them in terms of enrollment, but questions are asked about healthcare all the time. Questions are asked about how to use this care all the time. And so, scope. How far does this program work for you, and what are they allowed to do, what are they not allowed to do, and what kind of training could back that up? And now that we move to the next phase, as people are coming back, where do you see this going? Or are we going to, will they be able to do it, or are you going to actually now need to credential and certify and everything?
Well, I'll jump in. I think, to me, the scope question is prefaced by the resource question. The helpers have been under-resourced in most places, and so even if you made them sat through 100 hours of training, I think they're having trouble making payroll. They can't see all of the clients who come in for help during open enrollment. They're turning people away at the deadlines. And they're worried about whether they're going to be able to come back. A lot of them a lot of programs have seasonal workers, so they staff up a lot, and the federal call center does this too. They staff up during open enrollment, and then they lay off 2/3 of their workers, and then they go out and find new people and staff up again at open enrollment. So that adds to the difficulty of this. The law requires marketplaces to support their navigators financially out of the operating revenue of the marketplace. So all the plans have to pay a tax to be in there, and that's supposed to fund all of the work, including the in-person enrollment assistance. And Elizabeth's state is doing that. Most states aren't doing that, and the federal government isn't doing that. They're kind of, they're also because money's tight, but they're trying to get the website working and all this other stuff, and they have limited bandwidth, and then it's like, oh, and we have to find some money for the navigators, and then they pull together money, and then what happens to Janet's program happens.
Let me make it a much more concrete question then. What's the hourly income of a navigator?
I don't know. It varies.
Dependent on the state.
It would depend. It varies.
Yeah.
I mean, yeah, the salaries for our, people in our navigators can be at, we're not in Mississippi, so the wages are higher in New York than they would be in Mississippi, but some navigators will have about $46,000 a year, and then others, depending on the agency, will have as much as $59,000, so that would be their annualized salary.
Fabulous job in Louisiana.
That's more than that.
I just wanted to
She called you Mississippi.
Janet, how much are your people?
Well,
They were part-time clinic.
right. What
workers.
we did, I had a few that were part-time that were not non-clinic staff, and they were making about $15 an hour. I echo my background, social work also, so that's what I would see is that individuals were hired to be navigators, and they really did not have the skills to dig deeper and find out what the problems were, what the issues were as far as learning if their client understood the whole process. But yes, the salaries, we had $80,000 to do everything. So that kind of tells you that included promotion, mileage, paying people, so that kind of tells you where we were.
But I think your premise is correct, that this should be, and I think was intended to be, a profession, right? These were supposed to be professionals who knew what they were doing, who could come back to develop relationships, help people year after year, provide valuable feedback to the policymakers so that they could fix it. I see that from our survey beginning to happen. So we see of the 30,000 navigators, 5,000 programs out there, there are a couple of hundred that help more than 1,000 clients each open enrollment. I mean, these are pretty big operations, not huge, but and then we see, and those few programs provide about 80% of all of the marketplace in-person assistance that happens during open enrollment. And then we see a lot of these other much smaller programs that really are kind of scraping by, and they're helping maybe 50 people during open enrollment because they're just not as big, and they have maybe one half-time FTE and so forth. So I think we see developing within the huge community more kind of talented, more resourced, more professional navigators, but I
do think that does happen.
Yeah.
We chose deliberately not to have people enroll folks, so we created partnerships with people who enrolled. Our people were doing outreach and education and then direction. Right? Here's a referral. And with the referral, it had to be to a person, not to an agency. And we chose to develop relationships with people we knew who knew how to get folks in the system and would be around in that regard. So,
In Louisiana, to add something, even the FQHC clinics in Northwest Louisiana did not employ full-time navigators. They also trained people who were on staff, who were maybe a frontline person there and they did it part-time. So, and the FQHCs were not funded to do the outreach. We had to do the outreach and the enrollment.
Right.
So it was.
Yeah, there was no funding for outreach. I mean, outside of, like, California had the foundation support, but in the Navigator program, they didn't fund outreach. It was for enrollment services only.
Katina, but Michael, I'm going to get back to your question because I don't think you really meant it as an offense. I think you meant it as a positive to be sure that there was some professional guidance, but I will get back to that in a few moments. Katina?
So I'm Katina.
He looks like he can speak for himself. But
Michael is known
truly-
for
yeah.
being in touch with his moral outrage at all times, so it's not at all personal.
So
I'm all about moral outrage, but I don't feel like the navigators are offensive.
Okay, so I'm Katina OLeary. I come from Health Literacy Missouri. We are the technical assistance provider for the Cover Missouri Coalition. There are about 900 organizations in the Cover Missouri Coalition. This training question that we started with earlier, I didn't jump to answer it because myself and Dara Taylor are going to talk a little bit about training as well as support to navigators as we go on. So I just caution everybody that this is session 1. At the beginning of the day, where there's a whole bunch of stuff. So it's pretty cool that we're getting into this level of excitement, energy, and connection to materials. As a planning committee member, we wanted to start with this level of kind of on-the-ground folks who were really connected to the people and the resources, but don't be alarmed yet, more is coming. And I'm not gonna kind of hijack my own presentation that comes next by telling you what we do in training, but there's a whole lot of health literacy training and support. They paid us a bunch of money, relatively, because we're not an expansion state either, and there are not that many resources. But the Missouri Foundation for Health has really invested and done a good job. And there's a lot of resource in this and a lot of thinking that's transferable, generalizable, applicable, shareable, giveawayable. So stay tuned.
We will stay tuned.
Hi there, I'm Amy Cueva with MadPow, and I have a comment as well. Insurance is difficult to understand, not just for people that are new to the game, but to your point, all of us. I work with a lot of health insurance companies, and the people at the health insurance companies don't know how the plans work. They're extremely complex, and that's a big part of the problem. Another part of the problem is translating, co-insurance and deductibles and co-pays, things that people don't understand into terms they understand. They want to know, is my doctor going to be in network? How much are my meds going to cost? How much is my care going to cost? And they can't do the math associated with, okay, this is my premium, this is my deductible, this one is what might happen if my kid breaks their wrist, et cetera, et cetera. They can't visualize what it's going to be like in actuality, how it's going to hit their pocketbook. And I think we should be helping people finance deductibles in creative ways, and that's part of the problem because fiduciary responsibility just drops off a cliff when it comes to insurance. But just a point about the web, this thing came out in 2006, that was 10 years ago. The stats of web usage of 5 years ago, 3 years ago, last year are not the stats of right now, are not the stats of next year, so we can't judge future capabilities. So when we're designing for the future, we need to consider, to your point, again, what's going to be best for the demographics we're serving. The aging population has been late to the digital party, but they are the fastest adopting segment, and they're becoming party animals. We're also, it's true, and we're also seeing, and I'll dig up the stats on this because I think AARP has done some research there, but also in urban settings, I think the stat is now that people are more likely to have a phone than a home. And of course, they might run out of data, but we can't minimize the opportunity to engage people digitally just because it may have been inept a few years ago. So that's just a statement.
I want to comment. One of the things I learned from Janet's navigators when I was doing some focus groups over there, they were overwhelmed trying to get everything offline. And so they wanted a hardcore manual, and this taught me something about stuff I'm doing in healthcare. I still, at this point, 2016, a lot of people still want a little paper manual so they can refer to it and not have to start navigating when they want to answer a specific question. So I agree that, the old folks are leaving new technologies here, but still, I still would like to talk to one of y'all for help with insurance.
Let's talk about what a navigator needs to be able to show. You need to be able to show plan-by-plan comparison. It's going to be really hard on a phone. It's hard on a desktop or a laptop.
Yeah, whether it's verbal or printer.
And it's, and it's really hard. I mean, I think for certain communities, web stuff is really accessible and second nature, but for other communities, it's really not. And if we're talking about the last mile of the eligible but unenrolled, it's not the people that are on their, it's not the party animals, it's the non-party animals, it's people that don't want to go to the party. and are, have to be dragged to the party.
Yeah, and whether it's a verbal communication, a printed communication, or a digital communication, I think it's closing the gap between what people know and understand and how things really are. And I think that's where we're kind of struggling, no matter the medium.
I mean, in New York City, we have 97 plan options. It's not going to be on a phone. You're not going to be able to enroll someone on a phone.
As people communicate at different levels, right? And that's the part we have to be cognizant of. Now, when you said this when you started, Terry, that this is very individual. It's very personal to us. Some people, and that's why I brought out the conversation, is that when I communicate with my 25 and under crew, and I really want their attention, please come into my office via the text, right? Because we have to figure out how to communicate.
Call them on the phone, they don't know what to do. They don't answer.
They don't answer the phone.
They don't answer.
Right? You text them and tell them to pick up the phone.
Exactly.
That's what I do.
Or we don't
So,
do that with
Cindy?
we meet people where they are.
Yeah.
And that's how we have to communicate with them.
That's a good answer.
Gotcha.
That's a great final comment. We're all ready for that last sentence.
No, Cindy and then Ernestine, so we'll be fine.
I want to pick up on the theme of dragging people to the party and talk about the IRS penalty and ask whether or not you have, is part of the navigator's education to try and explain that everyone is required now to have insurance, that there could be a financial penalty, and how does that work into the education process?
Well, so it's, yeah, I think the penalty has, as it has increased and phased in, has brought more people in to at least look into what they need to do. But it's also the whole kind of tax component of this has added a whole other layer of complexity. So you not only have to get good about insurance, you have to memorize TurboTax because it's not, right? So you have to not only know the tax rules about what the penalty would be and what it would take to be exempt, but the whole kind of tax treatment of reconciling your premium tax credit, which I think is still kind of an untapped problem, but I know that the assisters are seeing it. You have to kind of project what your income is going to be for the year. You get your subsidy based on that. Then the following year, you file your taxes for this year, and then you realize you were off by this or that, and then you may have to pay some or all of it back, or you may not. And bleh. So, and the tax assisters are another kind of professional community that I think needs more help getting educated about this, because a lot of very low-income people who go to tax assisters to get their EITC tax credit every January are seeing a lot of that getting taken back to repay penalties that maybe they don't even need to repay, and that can't be helping people kind of sign up and stay enrolled either. So that's a whole other dimension. You can do a whole roundtable just on that.
And it's increasing the distrust also, especially depending on how much they pay for the premium and the deductible. It's like, wait a minute, where am I breaking even here in this regard? So,
Last question from what has been a very interesting morning.
It has been. Ernestine Willis, I'm a pediatrician at the Medical College of Wisconsin and one of the panels for the Health Literacy Roundtable. I appreciate the complexity across the country that we have from state to state, and I sincerely appreciate how you've added some detail, but I'm sitting there, still want to make some comparisons, so I guess I want to ask the panelists. I appreciated that Elizabeth is $5 million, and I don't have any idea what population breadth you're trying to cover. Is that the whole state of New York? Yeah. The same thing with you, Jan. I don't know for the education component, what piece of it are you being paid as that would compare to New York? And then I really appreciate your challenge in Louisiana when it comes to your 82,000 and what's the population coverage for that. So would you, each of you briefly just give me some idea of, while I recognize you're different and your demands are different, rural versus urban, but I'm trying to understand the comparison by population for the investment and the variety of, I'm not doing enrollment, I'm only doing education and outreach.
So for California, in terms of the education and outreach, Black Women for Wellness was part of a coalition that was put together by California Black Health Leadership Network. That coalition got $1.2 million to cover all of California. Okay, the 1.2 million to cover all of California, that was 14 agencies. So looking at Los Angeles is where we do our basic work. The catchment area in terms of the neighborhood where our office is 1 million people, but Los Angeles County in itself is close to 10 million people. Okay, of that $1.2 million, we got approximately 80,000.
New York?
So in New York, there were 3 million uninsured, the state population is 19 million. There were 3 million uninsured people when we started, or around 10% of our population was uninsured, a little more. My program got 5 million, but we were in 61 out of 62 counties. Other programs got, you know, whatever, like anywhere from 200,000 to $1 million. I'm not sure what the other navigators got. There were 50 navigator programs in the state, and so I was only one of those 50. But we got the lion's share because we tried to do a statewide approach because we really believe in our learning community and all that stuff. And so far, 2.8 million people have enrolled in the New York State of Health Marketplace. But remember, some people enroll and then move off, and so then new people come in. So the uninsured insurance rate has gone down from roughly 10% to 5%, according to the CDC, since the rollout of the Affordable Care Act. And we believe that per FTE, navigators are enrolling the bulk of the population. I mean, they're doing more than per FTE. They do more enrollment than any other assister. There's certified application counselors, there's plan-based enrollers, there's brokers, yeah.
And Shreveport, which I do believe is still part of Louisiana?
Yeah, for right now. I guess our Northwest Louisiana area probably has a population of about 450,000, do you think so? North, but that doesn't include the eastern part of the state. So I guess from Baton Rouge on up, how much do you think we
State has 4 million people. We are now, with the new governor, taking a Medicaid expansion, and we're enrolling 375,000 people.
That's amazing. It's really
But
amazing.
we had, as an example, in Monroe, Louisiana is about 120 miles east of us, and we had individuals calling from there. There was nobody looking for help, so we were trying to get people there. Sometimes they would drive 120 miles to us for an appointment with one of our navigators. So it is just very limited and very scarce as far as resources for all of North Louisiana.
Well, thank you very much. Terry and the panel, Karen, thank you very, very much. Let's take a 15-minute break, and we'll be back at 10:50 and start once again. Thanks very much.